Welcome back, everyone. Today we're diving into a topic that sits right at the intersection of dermatology and cardiology. We're looking at the epidemiological evidence linking hair loss to heart disease. This is a comprehensive review of androgenic alopecia areata, and cardiometabolic risk. I'm Dr. Fernandez, and this is Cardiology 305. Our goal today is to move beyond the urban legend and look at the hard data. We'll outline the associations between different forms of alopecia and cardiovascular disease, review the heavy hitting meta-analysis, and examine how pattern, severity, and age change the risk profile. Most importantly, we'll discuss the why, the pathophysiology, and why this means for you in the clinic. Here's a roadmap. We'll start with the basic of AGA and AAA, move into the core epidemiological evidence, break down the risk modifiers, and finish the clinical guidelines and a summary of the key takeaways. AAA, alopecia areata, and androgenic alopecia. Before we look at the numbers, we have to define our terms. We need to distinguish between the hormonal pathway of androgenic alopecia and the autoimmune pathway of alopecia areata, while setting the historical framework for why we even started looking at the scalp to predict heart health. Androgenic alopecia, AGA, is the most common form of hair loss, affecting half of all men by age 50. It's driven by genetics and DHT activity, which shortens the hair growth phase. We use the Hamilton-Norway scale to classify it, ranging from simple frontal recession to severe vertex or crown involvement. Pay close attention to early onset of androgenic alopecia, which starts before 30 or 40, as that's a major red flag in the literature. Alopecia areata. On the other side, we have alopecia areata. This is autoimmune, not hormonal. It can range from small patches to alopecia totalis, losing all scalp hair, or universalis, losing all body hair. When we talk about cardiovascular risk here, we are looking at everything from heart attacks and strokes to the metabolic precursors like hypertension and insulin resistance. Historical context of the association. This isn't new. We've been tracking this since the early 90s, when Lefkoe first linked vertex baldness to myocardial risk. Since then, we've had landmark meta-analysis in 2013, 2014, and just recently in 2025. The Lu meta-analysis gave us the first massive look at alopecia areata and heart risk. Epidemiology evidence. Now, let's get into the evidence of androgenic alopecia. We are going to look at the big three studies, Yamada 2013, the Physicians' Health Study, and the true meta-analysis. Yamada et al., a meta-analysis. Yamada's work is the gold standard here. In a study of nearly 3,700 participants, they found a clear dose-response relationship. Severe vertex baldness carry a relative risk of 1.32 for coronary heart disease. Interesting. Frontal baldness alone, not statistically significant. The risk lives in the crown. Physician Health Study. Lotufo et al. 2000. Lotufo followed over 19,000 male physicians for 11 years. Even after adjusting for age and smoking, they found that as the baldness on the board vertex got worse, the heart risk went up. If patients had severe vertex locks, they had 36% higher risk of coronary heart disease event compared to those with full hair on the head. AGA severity and cardiovascular risk, dose-response relationship. The graph of the Physician Health Study makes undeniable there is a greater relationship. Each step up in baldness severity on the vertex corresponds to an incremental jump in heart disease risk. It's linear trend. Truth Eslick took it further, linking AGA to metabolic syndrome with staggering odds ratio of 4.49. They found that insulin resistance was the strongest link, with OR of 4.88. This reinforced the idea that hair loss isn't just about hair, it's a visible sign of metabolic pathway gone wrong. Younger men at higher risk subgroup. This is where it gets critical for clinicians. In men under 55, severe vertex baldness was associated with a 3.4 increase in the risk of non-fatal heart attacks. If the hair loss is early, onset and rapid, Framingham data suggests it's a signal of accelerated vascular aging. Metabolic risk factors, AGA. The odds. While the overall link of cardiovascular disease, the link of insulin resistance is high, and metabolic syndrome as well. The message is clear. If you see the hair loss, check the insulin and the blood pressure. Framingham and Copenhagen Cities Heart Study. The Copenhagen study is fascinating. They followed patients for 35 years. They found that baldness, when combined with other visible signs of either lobe creases or yellow fatty deposits around the eyes, xanthellamas, was powerful predictive MI with a hazard ratio of 1.57. A study showing stronger versus weaker association. To be fair and balanced, not every study is a slam dunk. While Yamada and the physician study show strong links, others like the ARIC study didn't see a clear dose response. We have to account for different grading scales and potential confounding factors like BMI. Evidence of alopecia areata. Moving to alopecia areata, remember this is a different beast entirely. It's autoimmune, which means the mechanism of risk is likely systemic inflammation rather than just hormones. In alopecia areata, the body T cells attack the follicles. This creates a chronic, low-grade inflammation that doesn't stay on the scalp. We see cytokine dysregulation and endothelial dysfunction, which essentially means the lining of the blood vessels isn't working as it should. Alopecia areata, the brand new 2025 meta-analysis of over 238,000 patients is a game changer. It showed an overall cardiovascular disease risk increase of 71%. But look at the severe cases. Alopecia totalis or universal, the risk jumps to an odds ratio of 3.8. This is massive. The Danish registry cohort. The Danish data backs this up. In hospital-treated cases, which are usually the more severe phenotypes, they found a 41% increase in arterial and venous events, including strokes and VTE. This confirms that when the AA is severe, the systemic risk is real. The AA severity subgroup analysis. If a patient has patchy AA, the risk isn't statistically significant, but as soon as it progresses to severe form, the risk nearly quadruples. In AA, severity is the only modifier that matters. Risk modifiers, pattern, severity, and age. So, how do we stratify this? It comes down to three things. Where is the hair loss? How bad is it, and when did it start? Baldness pattern. Pattern is everything. Vertex or crown baldness is the red flag. Frontal recession alone usually doesn't move the needle on heart risk. Why? Because the crown follicles are uniquely sensitive to metabolic and hormonal changes, but also affect our arteries. Dose response, severity of cardiovascular relative risk. Another look at the Yamada risk study starts 1.18 for mild loss and climbs to 1.48 for severe vertex loss. It is a ladder. The more scalp you see in the crown, the higher the clinical suspicion should be. Early onset is the silent alarm. Men who lost hair before 40 have a much higher prevalence of metabolic syndrome, an odds ratio of 10.5 in some studies. Rapid progression is also more dangerous than a static bald spot, as it suggests an accelerated aging process. Broader aging phenotypes. Copenhagen Heart Study. The Copenhagen study reminds us to look at the whole patient. If they have vertex baldness plus an earlobe crease plus centellasma, the risk for MI is significantly higher. They are all visible markers of what's happening in the vasculature. Now, for the how, why does the follicle on the head tell us about coronary artery? AG, androgenic and metabolic pathway. In androgenic, hair loss is about DHT, an androgen receptor. These receptors are just in the hair, they are in the blood vessels too. High androgen activity can lead to endothelial dysfunction and pro-inflammation. Lipid profiles is a shared environment. Metabolic syndrome in early onset. Arias Santiago found that 60% of early onset androgenic hair loss patients had metabolic syndrome compared to just 12.5 control. They also had significant more carotid plaques. The theory: hyperinsulinemia drives androgen production, which then kills the hair and damages the heart. It's a vicious cycle. Pathophysiology: A, immune and inflammatory pathway. In the AA, it's about the cytokines, interferon gamma and TNF alpha. This promotes systemic inflammation and can lead to subclinical atherosclerosis. We even see elevated cardiac troponin in some severe forms of AA. Shared inflammatory pathways. Whether it's AGA or AA, the pathway converge on the chronic low-grade inflammation, endothelial dysfunction, and dyslipidemia. The hair follicle is essentially acting as a canary in the coal mine for systemic health. Hormonal and genetic contribution. While the AR gene is central to AGA, genetic risk scores for baldness don't always predict heart disease independently. This suggests that environmental, stress, diet, and metabolic health is what actually bridge the gap between the hair and the heart. Confounding factors and shared risks. We have to be careful. Is baldness causing heart disease? Probably not. They likely share the same soil. Metabolic syndrome is the biggest confounder. If a patient is obese, has high blood pressure, and is insulin resistant, they are likely to have both AGA and cardiovascular disease. Most studies try to adjust for this, but the overlap is so strong it's hard to separate them entirely. Lifestyle and environment, smoking, stress, and high glycemic diet all make hair loss worse and hair disease more likely. Chronic stress, in particular, raises cortisol and insulin, which fits directly into the androgenic pathway. Mendelian randomization hasn't shown a direct hair to heart causal gene. Instead, baldness is a phenotypic readout. It's a visible sign of how your body is handling its metabolic and inflammation load. Key studies result. Here's your cheat sheet from Yamada to Lu 2025. The data is consistent. Severe vertex, AGA, and severe AA are significant markers of cardiovascular risk. Save this slide for your clinical reviews. So, what do we do with this information tomorrow morning in the clinic? Right now, no major society, not the AHA or the ESC, lists baldness as a formal risk marker. Why? Because we lack randomized controlled trials showing that screening bald men actually save lives. But the ESC does call visible aging signs informative. Use it as a prompt, not as a diagnosis. Pragmatic clinical approach, risk assessment. Here's a 3-step move. Identify the pattern. Is it severe vertex? Assess the metabolic profile. Check the weights and the labs. Stratify. If they're borderline, that hair loss might be the tiebreaker that pushes you to order calcium score or to be more aggressive with the statin. Identify the patient. Assess the 5 criteria of metabolic syndrome, calculate their 10-year risk, and add. Use their hair loss as an opportunistic prompt for a deeper dive. Think of a 45-year-old with severe Crohn loss since his 30s. He looks healthy, but his waist is 104 centimeters and his blood pressure is 138/88. That's undiagnosed metabolic syndrome. The baldness was the only reason he walked into the checkup. Case 2. Alopecia areata, severe form. Now a 30-year-old female with totalis. Her dermatologist notes the link and sends her to cardiology. We find elevated CRP and borderline carotid thickening. Early intervention here would prevent a major event decades later. Lifestyle modification and risk factors. The good news, the treatment for the heart also helps the hair. Weight loss, exercise, and the Mediterranean diet reduce the androgens and the inflammation that drives both conditions. We have to stay grounded. Most data is observational. We need more diversity in our study, especially in women and non-European populations, and we need a standardized way to grade wellness across the board. Future directions in research. Where are we going? We're looking at AI assisted grading, polygenic risk score, and watching the cardiovascular outcomes of patients on JAK inhibitors for the AA. The next decade of research will be revealing. Let's wrap this up. What's the most known? Severe vertex, AGA, and extensive AGA are markers for heart risk. Pattern severity and age are your modifiers. These conditions share a common soil metabolic syndrome and inflammation. Use the scalp to save the heart. Follow the crown, watch your young ones, and respect the inflammation in AA. Screen for metabolic syndrome, treat the whole patient. For the students and researchers watching, I've included the major reference presented in this presentation. Thank you for your time. Let's open the floor for questions. Remember, these are epidemiological association and clinical decision must always be individualized. I'm Dr. Fernandez, and this was Cardiology 305.